Right. Okay.
Okay, so this is a very heavy topic, but I tried to make it as simple as possible. So we'll go through. These are some of the SAQs where this topic has come out before. If you go through the past year questions, actually this topic is more important in the SBAs actually because they ask very intricate questions like the phases of the cardiac cycle, the action potential. For the SAQ, there was a curveball question in April 2023 where they asked about effective refractory period out of the sudden. So it's like if you know, you know. If you don't, then it's a very difficult thing to just write your way out. So I'll try and cover it in today.
Okay. Just glance through all the questions and stuff. Okay. Just read the 2013 structure and conduction. Okay. This is ion flux. April, ERP.
Okay. Kalau tak silap, 3% ke 5% yang pass.
Yeah. This is it's like what the important question. Until if you cannot answer, then it's like that very bad impression. You can answer that even in the essay, in the Viva. Okay, this is very basic. We expect you as a foundation to start as a foundation for part 1. You cannot answer the question, is the very bad impression. Even you get the 7 questions for Viva. This is very basic. You do very badly, then maybe it give very bad impression. Then maybe your marks will be very low. Okay, this is like a mandatory, must know. Okay. Proceed.
So very quickly, we'll just go through the structural features. The basic unit of the cardiac muscle cells are the cardiomyocytes, and they operate as a functional syncytium. Okay, so basically, a syncytium is a unit that functions together or carries out a function together. But because in the cardiomyocytes, they have a low resistance connections between adjacent cells, the atria and ventricles contract together when an action potential is generated due to the presence of gap junctions, which allow the rapid conduction of action potentials. So it seems like they are functioning together simultaneously, but actually they are not. It's just due to the presence of gap junctions, the action potential can be processed or transmitted through, making them seem like they're working together. They also have the sarcotubular system where they have both T-tubules and the sarcoplasmic reticulum.
Okay, very important. What is the important point? A low resistance connection between adjacent muscle, especially atria and ventricles, because they got gap junction. That's why the connectivity, and then the contract together. Okay, just remember that's a key point. That's a very important key point. Okay, remember that.
So we go straight into the cardiac pacemakers. So as we know that there are different structures that can be the pacemakers, but the primary pacemaker of our heart is the sinoatrial node. It lies in the right atrium close to the entry of the superior vena cava. My reference is Peter Kam Mosley and Chambers lah. So these are 2 mm thick and 8 mm long, and it's perfused by the sinus node artery. Normal discharge rate, different textbooks will say differently. So it's either 100 to 110. Some say 60 to 100. But if you just write 100, you won't go wrong. And like I mentioned, if the SA node activity is depressed, there are other pacemakers that can take over as the primary pacemaker and determine the heart rate.
Okay, that's why when we insert central line, isn't it? You go too deep, you trigger the arrhythmia because it is at the entry of the superior vena cava. Whereas you go too deep, it's touching the trigger. You can see the arrhythmia. Okay.
So I put in this infographic to show the different conduction velocities of the different structures in our heart. So we start off from the SA node all the way to the ventricular myocardium. So as you can see, for the SA node, it is less than 0.01 meters per second, all the way up to, if you can see, the bundle branches is 2 to 4 meters per second. And this plays a very important role. Later, I'll explain lah. So summarize.
Can you have a look again? Okay. Do you want to summarize in the next slide?
Yes.
Oh,
Okay, right. So we start off with the SA node, our primary pacemaker, 100 to 110 beats or impulses per minute. Now, if there's any defect or affection to our SA node, the second pacemaker that takes over as primary is the AV node. So you'll see the heart rate anywhere from 40 to 60. If the AV node is dysfunctioned, then the bundle of His can take over, and you'll see the heart rate become 40 beats per minute. And if there's any disruption or any dysfunction of the bundle of His, then the Purkinje fibers will take over, and you'll see the heart rate as 15 to 30. These are precursors to the heart block as well. Easy way to remember, SA node 100, AV node 40 to 60. So you just take at 60, take away 15, it'll be 40 to 45. Take away another 15, it'll be 15 to 30. All right? Very important question for SBA especially. So they'll ask if the SA node has a problem, what is the next pacemaker, and what are the heart rate if you can see on an ECG.
Okay, Nur Akma ada? Nur ada? Okay. Nur Akma. Panggil apa awak? Akma. Okay, Akma. So what type of pacemaker we call it? The AV node bundle of His and Purkinje fibers. What type of pacemaker? What is the name of that pacemaker? What type of pacemaker? Okay, all pacemakers, the main pacemaker is SA node. But AV node bundle of His Purkinje fibers, there's one terminology of pacemaker. Anybody knows? Tak bawa gula-gula ini. Boleh jawab kan nak bagi gula-gula. Huh? No. Type of pacemaker. Harul. Takiyuddin lah, betul. Taki, cepat. Tak tahu. Mana senior semua? Tunjukkan kebolehan. Presenter.
Conducting and contracting.
No. Mana? Where is Eng? Tak ada. Geraldine. Where is Geraldine? Yes. Which hospital are you from? Selayang. Okay. Yes. What type of pacemaker? No. Okay. No. Latent pacemaker. Latent pacemaker. You got latent pacemaker. Okay. Check what is latent pacemaker. So they are all under latent pacemaker. Yes. The function explained by Daniel. Because whenever SA nodes is not functioning, okay, they will take over as a latent pacemaker. They will take it over. But they will be suppressed by SA nodes because the SA node is very dominant. The impulse will be suppressed because the SA node is dominant and the SA node will the one that trigger one. But when the SA node dysfunction, then they will take over. Also because they are play as a latent pacemaker. That's right. All right. Proceed.
So we move about the pacemaker and the transduction of the action potential. I'll explain later at the end of the slides. We go into cardiac action potential. So it differs from the other action potentials, for example, nerve or skeletal muscle, in terms that it is longer than nerve. It is about 250 milliseconds, primarily due to the changes in membrane calcium permeability. Now, it is important.
Okay. Go back to the table. Okay. Can you just summarize from this table? Which one is at the fastest conduction velocity?
Fastest would be Purkinje, but either the bundle branch or the Purkinje.
Okay. Mana yang lebih cepat? Conduction velocity. Purkinje fiber? Alright. Purkinje. Right. It's about bundle of branch and Purkinje. Okay, the rate is about that. Okay, that's we're talking about the pacemaker rate, Latent pacemaker, main pacemaker. Okay, the conduction velocity. Why? Okay, You see the slowest, which one?
SC node.
SC node.
SC node.
Betul. SC node is 0.01 conduction velocity. All right. Okay, for KJ, they need fast. Okay. Sometimes the figures, these are the figures actually can be asked in SBA, sometimes as a introduction of the discussion. Okay, okay, can you describe? Okay, part of the conduction velocity and firing rate of all these contractile cells of the. All right. Next.
So if at all in the SAQ, it comes out pacemaker, compare and contrast pacemaker versus ventricular or cardiac myocyte action potential. This is a quite a simple summary of how you can put it in a table form. Best way to answer. You hit all the points. You don't waste time writing too many words as well. But I'll go into the specific details in the following slides lah. So again, we start off with whether there's spontaneous depolarization, what is the resting membrane potential, threshold potential, and so on and so forth. So according to Peter Kam, when we talk about the action potential, there's the slow response and the fast response. For slow response, we're talking specifically about the sinoatrial or the SA node. So for the SA node, if you realize that there is no resting state, all right, and it is a pacemaker potential that has rhythmicity, sorry. Why? Why is this? Because there's no neural input. It is not stimulated per se by the autonomic nervous system. It has the resting membrane potential of -60. Some, as Prof mentioned, different textbooks say different, but you can just take it as -60 millivolts. Phase 1 and phase 2, as compared to the ventricular cardiomyocyte action potential, are absent here as there's no depolarization plateau. So I took this graph from Chambers. It summarizes.
Before that, Daniel, I just want to from until this point, I want you to test your understanding. Qayyum, ada Qayyum. Okay, Qayyum. So from your understanding now, how you define pacemaker cells? This thing. Okay, okay. All right, okay, okay. That's sound different. Okay, this is pacemaker. You remember the word pacemaker? Pacemaker. It's something that triggers, right? Something that initiates, that triggers. Okay, that stimulates. Okay, the cell that stimulate the action potential. Okay, that initiate. So there's a pacemaker. It's not peace. Yeah, it's a pacemaker. So always something that from sometime other terminology, if you can remember, you can imagine one terminology, pacemaker was that. Then you imagine how you can define. From that single word, you can elaborate. Understand? Okay. So this is the main pacemaker. The pacemaker, the main cells that stimulate the action potential of the cardiac muscles. Okay. Okay, proceed.
So this, if ever we have to draw a graph, it is the graphical expression of the SA node action potential. On your x-axis will always be time, and your y-axis will always be the membrane potential in millivolts.
Okay, save the diagram in your mind. The diagram ni kalau in the exam, just go draw with the x-axis, y-axis, the labeling is right. Kan? Always all this important diagram because there is a mark in the SICU. Okay, proceed.
So if you're confused how to remember between pacemaker and other ventricular cardiomyocyte potentials, easy way to remember for SA node or pacemaker, shape dia macam A. Alright? And For an A, it has the upslope, the downslope, and a horizontal line. Your upslope is your depolarization, your downslope is your repolarization, and the horizontal part of an A is your it's your slow depolarization or your pacemaker potential. You remember one, the second one will come automatically. Right? The ventricular one is a bit more complicated, involves more voltage gated channels. So I suggest at least you remember one, you tackle one, the second one will be easier to remember. So we have the resting membrane potential at -60, the pacemaker potential, the upstroke or the depolarization, your repolarization, and then we go back to the pacemaker potential. So phase 4 is the slow upstroke. It is determined by the HCN, and these are permeable to both sodium and potassium. Right. Following an action potential, the membrane hyperpolarizes, which opens the HCN channels, allowing sodium and potassium to diffuse according to their electrochemical gradient. Okay, this differs from the ventricular one because once the action potential is transmitted, the sodium channels will open and there will be a major sudden influx. This one, they go according to their concentration gradient. This is where the inward sodium funny currents occur. So if you see this funny current word in the textbook, this is where it occurs. That's why there's a transient increase rather than a sudden increase or depolarization. So overall, the sodium influx slightly exceeds potassium efflux. Sodium masuk, potassium keluar, resulting in a slow depolarization of the cell membrane from its initial resting membrane potential of -60 to its threshold potential of -40. Now, once threshold potential is reached,
What is the other name of the hyperpolarization activated cyclic nucleotide gated cell? What is the other name normally they refer? The hello 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 hello. Huh? Why is the channel? No. A simple channel je by the it's not sodium potassium channel. Huh? No. It's a sometimes they just it's the book just refer by sodium potassium ion channels. Just simple on sodium potassium ion channel because it's exchange. Some book just refer to that. This is a more meaning more about better explanation on that. But sometimes they refer just sodium potassium ion channel.
okay. So we go to phase 0. Remember, phase 0 is the upstroke. So phase 0 starts off once the threshold potential has been reached, which is -40 again. Now, it is characterized by the opening of L-type or long-type voltage-gated calcium channels. So there's an influx of calcium ions. SA node potential reaches at about +20 millivolts. Very important fact to remember in comparison with the ventricular myocyte action potential transmission, no sodium current is involved in the SA node potential in the part of depolarization. All right. The sodium comes in according to its concentration gradient to reach the threshold potential. Once threshold potential is reached, then there will be an opening of the L-type calcium channels. Calcium will come in, there will be a calcium influx, and compared to ventricular is sodium. So once our peak potential of +20 has been reached, we go to phase 3, where repolarization starts to occur. Potassium permeability increases, and there's an outward flow of potassium ions. There's an efflux. So this results in increasing repolarization currents, causing an increase in potassium permeability and an outflow of flow of ions, like I mentioned. So in this infographic, you can see the different phases and the, which ions are involved. So remember, A shape 403. All right. So 4 is the transient increase. The phase 0 is the depolarization and phase 3 is the repolarization. Phase 4 potential, there's a slow sodium inflow and there's a slow potassium outflow. This is where the pacemaker potential of autorhythmicity is involved. Phase 0, fast potassium, and phase 3 is the decreased outflow rate of potassium by the rectifier cells. So in summary, SA node potential is caused by a process of constant changing membrane potentials, like I mentioned, sodium, potassium, and calcium. A cycle of increased sodium and decreased potassium first at phase 0, then an influx of calcium, in phase 4, phase 0, and phase 3 in potassium permeability.
So remember, that's very important. The ionic changes along the way of cardiac SNO action potential. This is one of the common questions, and you should be able to describe and explain what happening at the different phases of that. Okay, what happening based on ionic basis. Okay, kalau tak faham, baca lagi until understand. Memorize one thing, understanding is another important thing, because understanding is a long lasting. Even though when you are in the situation in the exam room, when the examiner you are panic, well, with the long lasting understanding, you should be able to answer. If you memorize without understanding, then you blank, top block totally. Okay, that's why because at the beginning, especially the newcomers, it's very important. This is very important. You really read and understand at this phase. The seniors, they pass that phases. They need to more drill of understanding and talking. For the new beginners, need to do some reading and understanding. Okay, right.
So we move on to the fast response cardiac action potential, which is the ventricular muscle action potential. Now they are longer compared to the pacemaker ones in terms of they have a distinct plateau phase when depolarization is maintained. Another difference is the RMP of ventricular muscle is about -85 to -95. Some say -90. All are acceptable. Another difference, the membrane potential undergoes 5 distinct phases in comparison to the pacemaker, which only has 3. And for the duration, the membranes are depolarized 0.2 seconds in the atria and 0.3 seconds in the ventricles. Now, sometimes there have been SBAs where they ask, why is there this difference of 0.1? It is to allow the atria to completely contract and for the ventricles to fill. So if you read Peter Kam, you read Chambers, they do explain about the 0.1 second delay and its importance. So graph, x-axis time in milliseconds, y-axis is membrane potential, millivolt. Start out with phase 4, we have 0, 1, 2, 3, and back to 4. So we start out with phase 0. It is the depolarization phase, all right? So remember, we're talking about ventricle here. So for ventricular muscle cell, it is characterized by a rise in sodium permeability. Again, for pacemaker, it's calcium. For ventricle, it is sodium. So the threshold potential for cardiac myocyte is around -65. So from -55 or -95 or -90, we go to -65 or 60, which is the threshold potential. Once the threshold potential is reached, then there's an opening of fast voltage-gated sodium channels. Therefore, there's a sudden rapid rise or depolarization state where the potential will reach of positive 20 millivolts due to the sudden increase of sodium permeability. They open only for a very, 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 very short while, and therefore it seems like a straight line up compared to your pacemaker potential. So, like I mentioned, the end result is an extremely rapid depolarization to approximately positive 20. And we go to phase 1, where it is a partial repolarization. So just now, the fast sodium channels are open. Now they close, right? So the sodium channels inactivate, resulting in a rapid decrease in sodium permeability, right? Now, Instead of the sodium, what happens is the fast voltage gated transient outward potassium channels open, allowing potassium ions to diffuse out of the cell. So that's why we get a decrease in the potential, right? That is phase 1. Phase 2, plateau phase. Very distinct characteristic of the ventricular action potential. During this phase, it is a long period, about 150 to 200 milliseconds, of relatively stable depolarized action potential. Almost a straight line, but it is still downward going. So if you draw the, make sure you don't draw it horizontal, but it's slightly downward going, which is a feature unique to the ventricular action potential. Now, this plateau phase is characterized, or it is that way because there's increased permeability as well to calcium channels with the opening of the L-type calcium channels. All right, so there's a permeability to the calcium ions, allowing calcium influx into the cell down its concentration gradient. Now, to sort of equal this, calcium is coming in, or there's a calcium influx, but there's an almost equivalent outward flow or efflux of potassium ions. Hence, we get that plateau phase, right? So for phase 2, plateau phase, sodium channels close, L-type calcium channels open. There's a calcium influx or coming in of calcium ions, which is almost equivocally opposed by potassium efflux. Now we go to phase 3, where there's a repolarization phase. But the plateau phase is terminated by the closure of L-type calcium channels, increase in outward potassium current, the delayed rectifier potassium current. So in all the phases, you realize when we start one phase, we must explain the closure of the previous whatever channel is involved. So for phase 1, closing of the sodium channels. For phase 2 to phase 3, we have the calcium channels. Phase 3, we close the calcium channels, and there's an increase in potassium influx. So once potassium goes out, the cell becomes more negative. Therefore, we reach our resting membrane potential of negative 85, negative 90. Phase 4, resting membrane potential is reached. It is stable as inward and outward currents or influx or efflux of ions are balanced. So again, similar infographic as the pacemaker, but this is in terms of the ventricle. So we have our RMP phase 4, we have our rapid depolarization phase 0, we have the closing of the sodium channels phase 1, the plateau phase phase 2, we have the repolarization phase 3, and back to phase 4. If you were to characterize the membrane potential, but they don't ask you in terms of millivolts or in terms of time, but they ask you about ion permeability. Remember, sodium first. This is ventricle again, to remind everyone. Sodium first, and potassium, you have potassium as well, and then potassium dominates. So this is in terms of ion permeability.
Back to the back to previous the one we this one. Okay, it's quite I can anticipate if naughty examiners will ask you. Okay, if they will ask you in the Viva, can you draw the action potential of ventricular ventricular active action potential? At the same time, superimpose the graph, the changes of ionic changes that happen throughout. So this is how they can ask. Okay, so maybe if you don't anticipate that this is the graph. Okay, so you can see the graph of ionic changes. Maybe you put the sodium pattern of changes, and then followed by the next. What happened to potassium? What happened to calcium? I think if you get this sort of question, you might be stunned a little bit. Right? So remember this graph. Okay, this is as a summary of what has been described by Daniel recently on what happening along the way of action potential, because there is actually basically the sodium, potassium, calcium will interact. So to summarize that, this is what happening. This is the action potential that happen. But throughout, you can see the superimposed thing. This is throughout what happening to the what happening to the sodium, what happening to the calcium. Okay. So how examiner can ask? That's the way they can ask you. Okay. Right. Don't let me ask that question. All right, proceed.
So in summary, phase 0 is a brief, rapid increase in sodium conductance, results in rapid depolarization. Phase 1, potassium conductance increases transiently. Phase 2, increase in calcium conductance, inward calcium current, opposing the tendency of the outward potassium efflux to restore the membrane potential. So this results in the plateau phase. Phase 3 is the depolarization, decrease in calcium conductance and a progressive increase in potassium conductance or potassium efflux, resulting in membrane repolarization. And phase 4, calcium, sodium, and potassium conductance have returned to resting levels, where you return to the RMP.
So okay, you can see the ionic bases that involve along the action potential is only 3 ion. Okay, sodium, potassium, calcium. Okay, whatever abnormalities that happen for this ionic bases, it will affect the action potential, isn't it? That's what happened to our ECG changes, isn't it? So for example, you got hypokalemia things. Okay, that's possibly or calcium as well. It can affect the action potential. Okay, the tricky part when they come to apply, this is tricky part, which I expect is the excellent question sometimes, excellent. But you can imagine sometimes, okay, what can happen to the action potential? What changes can happen to action potential when there is hyperkalemia? So normally we refer always to the ECG, isn't it? But it's sometimes they can ask that. You can try to figure out. Okay. But normally it comes to, this is the basic thing. Normally this is the strength, the difficulties normally they will ask lah. So from this one basic thing foundation, we want to see them possibly at the end they can. So, okay.
I think you all can go back and read this. It's just a
summary, yeah.
Summary, yeah. So we go into the conduction of the action potential. So from the SA node, all right, we go into the internodal pathways. From SA to AV, for the anterior part, we have the Bachmann pathway, which relays action potential to the left atrium via the Bachmann bundle. In the middle part, we have the Wenckebach pathway, and posteriorly, we have the Thorel pathway. In the AV node, it is the only means of transmitting action potential between the atria and the ventricles. So there's a delay of transmission, like I mentioned, between the atria and ventricles of 0.1, allowing the atria time to contract. And the AV nodal delay is a major component of the PR interval of the ECG. So SA, AV, bundle of His. So after they leave the AV node, the bundle of His divides to the right and left bundle branches. The left bundle branch divides again to the left anterior and left posterior fascicles. The Purkinje fibers, the branches of the bundle of His divide to form the Purkinje fibers, which rapidly conduct the action potentials throughout the right and left ventricles. So in summary, you can almost see a synchronized ventricular contraction. They terminate just below the endocardium. Therefore, the action potential conduction is performed by the cardiac myocytes themselves. The first part of the ventricular wall to be depolarized is the apex, and the last is the atrioventricular groove.
Why? Why the first part of ventricular wall be
the conduction of the pathway?
Anybody? First connection. Yeah. For what? I need a good, because the answer possibly when you answer, it can be close, but you want sometimes the exam want to get the accurate terminology, the keywords, apa dia? Why actually vertical wall to be the first part in the apex, and the last is a AV, anteroventricular groove. Kenapa? Anybody? Share. Jangan takut. This you are not undergraduate lah. Master student ni. Try. Tak apa, salah tak apa. Nak tengok what is you imagine. Apa Rol? Yeah. Why this conduction pathway has been arranged that way so that the apex will be contracting first. Synchronize one thing. One is because you should start from the apex to get a good ejection fraction, cardiac output. When they contract from that apex for good contraction to be, for the good cardiac output. Okay. If you find that one of certain books, they will explain that, because that's why they got conduction velocity go down to the apex. Then the first actually depolarization from the apex first, so that it can go a good cardiac, good ejection of the volume. That's a good cardiac output for to the answer. Okay.
So for a heart rate of an average of 75 beats per minute, the ventricular action lasts for about 250 milliseconds. Phase 0 and 1 have a total duration of 1 to 2 milliseconds. The summed activity of phase 0 and 1 across the septum and ventricular wall corresponds to the QRS complex of the ECG. Phase 2 lasts for about 200 milliseconds, corresponds to ST segment. And phase 3, around 50 milliseconds, corresponds to the T wave of the ECG. So like Prof say, if we want to superimpose mechanical and electrical, always remember electrical first. This is something that the textbooks also emphasize, our bosses also have always taught. So electrical first, then only mechanical. So if they ask the sequence of what happens, you get the electrical first, and then only you have the mechanical phases.
This is one of the important diagram as well. Always one of the favorite question, they would like to use superimpose to understand your understanding. Superimpose of like, this is a cardiac action potential with the ECG, what happened. Okay, so that means you have to draw one and then correlate with the other one and explain how it relate to that. Because the event doesn't occur in silo, isn't it? It reflects to the others. So this is mechanically you reflect to the ECG. That's what happened. At what point of cardiac action potential happening that you reflect to the mechanically on ECG. Okay, this is always when you read the topic for the master, always you anticipate what they're going to ask, how you're going to explain, and how this is this explanation relate to this explanation. Okay.
So what's the relationship of all that we mentioned and refractory periods? So most of the textbook will actually define the periods into absolute and relative. But like you can see in April 2023, they actually mentioned effective. So I'll touch in that in a while. So in the ARP, or the absolute refractory period, a further action potential cannot be initiated, no matter how large a stimulus is applied. So if you were to try and understand this better, like TOF, you have the supramaximal stimulus and all that, no matter what, an action potential cannot be initiated, no matter how large a stimulus is applied. So the ARP lasts for about 200 milliseconds, and no matter what, during this ARP, action potential cannot be triggered until muscle contraction is nearly complete. Keyword nearly complete, I'll explain in a while. If the ARP is short or shortened, it can potentially lead to tetany of the cardiac muscle, which would be incompatible with diastolic filling. Now, bear in mind, we were talking about calcium conductance. So here, like Prof said, when we talk about electrolyte disbalance, hypercalcemia and things like that, so all this will affect your periods as well.
Okay, Taki. Okay. From the explanation by Daniel, can you tell me what you understand about absolute refractory period? Okay, very good. Okay, very good. Because I just want to test you how you come up with your own words. Absolute refractory period. You start with period first. Good. It's a period. It's a duration. It's a period where where the cardiac muscle cannot be stimulated. Okay? Even though any supra stimulus. Good. Absolute mean nothing. Nothing can be. Absolute refractory period. The duration absolute. You cannot even any supra stimulus also cannot trigger action potential. There's a duration where absolute refractory. So refractory is a static lah. I mean no activities. Kan? By your own words you can come up with your own explanation of that. Kalau you cannot remember the exact word in the textbook from the single terminology, you can come up with the explanation. Same relative. Relative means it's not absolute, isn't it? It can happen at any point, at any triggers, any stimulus, which is okay, a supramaximal stimulus. Understand? Okay, that's how I want you to come out the concept. All the in physiology, the terminology given with that single word, you can imagine, you can understand why. Pacemaker, latent pacemaker, contractile cell, absolute refractory period, play two phase. Why? Isn't it? From that word, then you can imagine, and even you get the imagination of what, and you can explain by this. Even you can understand. Okay.
So RRP basically Prof helped me explain. So this from the textbook to actually just show the phases or the period, sorry, ARP and RRP. But I managed to find this where it explains the ERP. So for ARP, the absolute refractory period, all right, the key point is sodium channels are closed. Okay. The ERP is contained in the ARP and it is also part of the RRP. ERP is the effective refractory period. At the end of the ERP, sodium channels begin to open or recover. There is an influx of sodium, all right, but the action potential still cannot be generated. Why? Because there is inadequate or not enough inward current. Okay, if you remember just now the April 2023, they asked about the ERP. What is its significance? So basically it's here. So it is the start of the opening of the sodium channels. Sodium influx is occurring or something like that, but the AP still cannot be generated because there is inadequate inward current. RRP, as we already mentioned, is almost at the end of the ARP. More sodium channels have recovered, and you can generate an action potential here if there's a supramaximal stimulus or an adequate stimulus. SMP, most textbooks mention it, but usually for the questions, roughly when I glance through, it's basically either ARP, RRP, or in April 2023 is ERP lah. So I just touched a bit about the ANS influence of the heart. Yesterday, Dr. Badiha actually explained it very, very well. So I'm just going to summarize. So for the ANS, we have the sympathetic and parasympathetic influence of the heart. I move to sympathetic. So for the sympathetic, it is the postganglionic sympathetic fibers from the upper thoracic T1 to T3. An increase in SNS activity causes a release of noradrenaline and adrenaline from the adrenal medulla. Both act on the cardiac beta-1 adrenergic receptors. They are GQ. So from GQ, if it is activated or it is enhanced, you have increase in pKa, IP3, DAG. From there, you have an increase in your CMP and protein kinase. Active chronotropy in the assay note, increased CMP opens the sodium-potassium channels, which increase sodium influx, and therefore there's an increase gradient of the pacemaker potential. I will show this in the next slide. So in summary, what does this mean? The threshold potential is reached faster, therefore there's an increase in heart rate. So if at all we have a question, an SICU question that says, draw the influence of an increased SNS on the heart rate, so, or the pacemaker potential. First, draw the normal pacemaker potential, and then for the increase in sympathetic stimulation, you will see, like I mentioned, there's an increase in gradient. So the slope will be higher, faster, so the heart rate pun akan jadi lagi laju. So positive inotropy, increase in myocardial contractility. Why? Because there's increase in calcium influx during the plateau phase. Shorter action potential duration, increase in pKa, opens the delayed rectifier potassium channels, and increase in rate of transmission. So all of those words are drawn in your graph. So increase in gradient, faster heart rate, increase in myocardial contractility.
Okay, how many more slides? Almost, okay. Just you give a summary of the parasympathetic.
Okay. So for parasympathetic, basically it is the reverse of what we mentioned, but it's actually, like Dr. Badia explained yesterday, and it's important to note, our resting heart rate or our pacemaker heart rate is mainly controlled by the vagal tone of the heart. Okay, so yesterday she explained very, very well, and I'm just hopping on. So it is the parasympathetic that actually supersedes the sympathetic in our normal circumstance. Our vagal tone dominates. That's why we have our resting heart rate and our pacemaker potential. Everything goes well according to the vagal tone. During an SNS increase, there's an increase in firing. So when you write your SAQ, it is important to note there is a decrease in parasympathetic outflow and there's an increase in sympathetic outflow. Then only you explain why one overcomes the other. But if there's an increase in parasympathetic, it's the reverse. You increase the outflow of the parasympathetic and you decrease the outflow of the sympathetic. So the gradient will decrease. You will have less cardiac contractility. You will have a slower heart rate. So when you draw your baseline axial potential, you make sure you decrease the gradient, you decrease the slope. Heart rate becomes slower, your whole graph becomes longer.
Okay, good. Okay, so I just try to summarize just two things. So this topic is very basics, okay, and very important, and common topics. In the common topics being asked in the all SBA, SIQ, and even Viva. Viva definitely, there's one question will be on cardiac action potential because you got the cardiovascular. So I want you for those the newcomers, okay, baca betul-betul Just okay, this is to give you a highlight, and then I give you another additional things for you to think of and to understand. Okay, but the other important thing for you to read again. Okay, you cannot understand from this textbook, read another textbook so that you can make a summary, a notes, and until you understand, and then try to draw and figure out all the important diagrams. All that presented by Danny is an important diagram that can be asked in the exam. Okay, this is, I think, very important topic. It's you cannot answer. It's a mandatory. It's like suicide Suicide, fail. Okay. So it's very important. Simple as that. As an anesthetist today. Okay. So, and every day when you read, understand, and then all other things that, so you go back to the OT, ICU, try to always remember, improving, because we're always dealing with the heart. Tachycardia, things, action potential, at least try to always trigger, recall, okay? So always, I want you to continuously like that. The first thing, before you come to CME, read, glance about the topic. Come, listen to the presentation, do some homework on that, balik buat nota ke sebagainya ataupun sebelum tu. So you kena banyak benda, banyak phases you enhance, and then jawab soalan, and then talk to yourself, explain. For those preparing for exam, you tak boleh kata, okay, dah lepas teori you tak. You kena prepare dua-dua sekali dah. Because you are at different phases of preparation. Where for the theory and to converse how to answer in the viva. Kena dua-dua. Kan? Baru you really prepare. Sebab you cannot, okay, pas teori baru nak fikir. Tak ada. You tak ada masa for that. Because sometimes your attempt is very it's reduced dah. Tak ada. So that's how you have to strategize yourself. The exam is about strategy juga. Part of the knowledge is a strategy. Dan kena endurance kena ada. Dan time running very fast. Dan have to be teamwork each other. Kena help each other. Tak boleh kena in silo working. I think if you best student last time, you working alone as undergraduate, not necessarily you will pass this time. Understand? Kena sebab it's a different battlefield. Okay. I think I conclude the session. Okay, I hope you capture whatever few things that I highlight. Okay. Boleh. Thank you. Thank you, Prof. Okay.